with Fink, the place that you need to be every single Tuesday evening. It is 5 o'clock on the Gulf Coast, which means 6 o'clock on the East Coast, and 4 o'clock in the mountains, 3 on the west. And every Tuesday evening at this time, we get together here to talk about all those things that are important to us. And that is the things about making a family. That is the things about getting pregnant. That's the things about gynecology and obstetrics and being female and being families and reproduction. And it's not just women, it's men too. We got everything going on here, and a very special good evening to all of you. Hello to Amber. You are my number one today. Thank you for being the first one to join here. We had such a great time this morning with your very exciting news, and I don't want to share anything and tell anybody anything that you wouldn't otherwise tell them, but good news in the Jones front. How about that? Yes, indeed, absolutely. I am a fertility gynecologist right here at New Life Fertility in Pensacola, Florida. We have offices in Mobile, Alabama, and Panama City. I also work with the Missouri Center for Reproductive Medicine, MCRM, with offices in Chesterfield, Missouri, in the St. Louis area, and in Tulsa. We see patients from all over this great country of ours, and my colleagues and I can see you virtually and at any place that is convenient for you. So pick up the phone and give us a call. Hello, Ruger. Nice to see you here this evening to join me for a few minutes. We've got my Instagram feed right here, and I'm Randy Fink, MD. Hi, Kayan Davidson, Wide River. Hi, Noodles. Good to see you. And Marlena, good evening. We've got Facebook, a couple of different Facebook feeds. LinkedIn, YouTube, all right here. We've got another Instagram feed for New Life Fertility over here, and we've got Katie B doing things. Hey, Katie. Hi, Sarah. Florida Panhandle Matt, it looks like. You were the first to join over here on this side, so thanks so much for being here this evening. Hey, if you got questions about all these things that are important, please throw them out here. That's what we're here to talk about tonight. And I just wonder how your life's been this week. It's pretty cold here on the Gulf Coast. It's 54 degrees now, but gosh, I think it was about 30. I was in the 30s this morning. I had some ice on the car, and I have to say that's pretty unusual for being here. I spent a few days last week, Wednesday night through Sunday, in the St. Louis area, helping out with my colleagues at MCRM, and it was cold. Actually, the first day, I think it was probably warmer there than it was here in the Florida Panhandle, but then it got pretty cold for a few days. So it's always nice to come back to Florida, but not when I get back here and it's 30 degrees. It's not supposed to be like that. Kristen, hello, good evening, and my dear friend Angela, hi, how are you? It's nice to see you. I hope you all had a really good weekend, and so far the week is shaping up well. I will ask. We're going to have a special time, as you know, come 5:30. It's time for the Fuzzies with Fink, and I actually will have a special request for all of you at that moment. So if you can stick around for another 20 minutes or so, the Fuzzies with Fink is the time that we get together and really stand together as a community and send out our good wishes to all those people who are needing those good wishes. And it seems like the world is getting to be a pretty challenging place. And every single week that we look at the news, we say, gosh, there's a lot going on out there that affects us all in the world, but also in our lives, in this fertility business. And certainly in our relationships and in work and in school and all those things that are important. So we'll talk a little bit more about that in a few minutes. Noodles for Life says my medicated FET cycle got canceled after 60 days suppression due to my lining not responding. Okay, well, so that is it's not an uncommon finding. So let's talk about what's happening there. So Noodles was planning to do a frozen embryo transfer cycle, but apparently had been identified as having endometriosis. So how do we diagnose endometriosis? You can diagnose endometriosis by surgery, or now we can also diagnose endometriosis non-invasively through a test that's called the marker for BCL6, also known as Receptiva. If you'd like to read about that Receptiva test, they have a nice website. It's Receptiva, ReceptivaDX.com. And that will tell you everything you need to know about that BCL6 marker. So we typically use it. We use it really to diagnose inflammatory conditions like endometriosis. So in the face of endometriosis, what we have learned is that we want to turn that inflammatory marker off. And the reason for that is because it opposes your body's own progesterone hormone. And progesterone is the hormone that your body needs in order to maintain a pregnancy. So usually what happens is that we come to do that test and to make that diagnosis in someone who has had recurring implantation failure. That is, you keep putting embryos in and they're not sticking, and we want to know why. Well, it used to be we'd say, well, you got to have surgery. And let's see if there's endometriosis. Now, through this non-invasive test, we can see BCL6 is positive. That's the reason. So what do we do there is that we give you suppression. And we use that term a lot. We talk about suppression on this program a lot because it's a pretty common thing to find. And that is 60 days of a hormonal medication where we are, or actually a medication that is turning off the hormonal supply to the endometriosis. And that will shut off endometriosis. That will turn off the BCL6 marker. We found that 60 days seems to be the adequate period of time. Well, if you're pulling the plug on your hormones, then sometimes it takes a little bit of time for those hormones to figure out what they're supposed to do again. And Noodles, it sounds like you did your 60 days of suppression and then you started on your estrogen, but your lining never really got thick enough. In most cases, if you just sit out the rest of this cycle, give it a little chance, then your pituitary gland connects back up with the ovaries. You figure out how to start making estrogen and estrogen receptors again, and things just kind of reboot and reset. That's what happens most of the time. So it's not uncommon. Now, I am certainly a fan of the modified natural frozen embryo transfer cycle, or an FET, modified natural, which is where we let your body's own hormones sort of take the front seat. But I will tell you that doing that after suppression is very difficult because most of the time, the body's not going to cooperate. It just takes a little time, even though you finish your medication, your Orilissa, or you got your Lupron shot, and then it's shut off. Then your body still takes a little bit of time in order to figure out how to go back to doing what it's supposed to be doing. So I wouldn't consider that an alarming thing. And my expectation is that it's gonna come right back in the next cycle. Now, there are some things that we can do for folks who have a difficult time building their lining. There's a medication called Neupogen. There is some Viagra we can use, which increases the blood flow going to the uterus. We can use baby aspirin. We can use a different type of estrogen. We can use transdermal, a skin patch. We can use oral. There's even an injection that we can do that often works well when the others are not. And there's also intrauterine PRP. So we've got a lot of tricks up our sleeves there. My guess is, though, without having to do too much more, it's going to sort itself out and figure it out. So next month, fingers crossed here, friend, better luck. A special good evening to my friends at MCRM. Hello, Dale. Thank you for being here and for watching the program this evening. And to all those in the MCRM area, it is really always a pleasure to be with such wonderful, wonderful people. I will be going back. Let's see. I will be in Tulsa doing transfers during the month of March. So just in a couple of weeks, be back there. Looking forward to seeing my friends there. Also a great place to visit. Let's see what else we got going on here. Dancer says, Doc, do you recommend an HCG wash and or boost for a frozen embryo transfer? So HCG wash is not a bad thing to do. And basically what we're doing is we're taking a little bit of the pregnancy hormone, and that's the HCG, and we're placing it inside the uterine cavity. And that's what's known as an HCG wash. What does it do? It puts all that pregnancy hormone right onto the lining of the uterus, which turns up the volume knob on some of those pregnancy receptors and is said to be helpful in some circumstances. Is it necessary for everyone? No. People get pregnant without HCG washes all the time. In fact, the American Society for Reproductive Medicine says we should not be providing all this different immune stuff to the general population because most people don't really need it. But does it hurt? And the answer to that is no, it certainly doesn't hurt. There's a little cost to it. It may be a little bit crampy, but it's not a dangerous thing to do. So it may help. And in most cases, I think it's affordable enough that if it's an option for you and you'd like to do it, there is certainly no harm. Now, as far as HCG boosters go, an HCG booster is a little injection, usually of about 250 units of HCG or pregnancy hormone, that you give yourself subcutaneously every day after an embryo transfer. That can be meaningful if you have done a natural or a modified natural FET. If you did a medicated cycle or are doing a medicated cycle, I absolutely 100% do not recommend an HCG booster. Is it going to hurt anything? No. But is it going to help anything? No, because what that HCG is doing is that it is basically being converted in your body into more progesterone. But when you're doing a medicated cycle, we give you so much progesterone that a little bit more that your body's naturally going to make isn't going to make a doggone bit of difference. So it makes people feel like they're doing something because they're injecting themselves a little bit more every day. But really, honestly, it's unnecessary. The best use of an HCG booster is in a situation with in a natural cycle or a modified natural cycle embryo transfer, particularly in situations where you may not make enough progesterone, even though truthfully, if you're making enough progesterone, you really don't need to do it there either. But hopefully that's helpful. Hi, Kimmy Girl, and hello, Stephanie, Florida Gator Girl. Let's see, I saw my friend here, Angela, asked, Plaquenil is 200 milligrams. Is once a day or twice a day more standard? So the specific indication for Plaquenil, also known as hydroxychloroquine, has to do with particularly people who have a positive blood test known as an ANA. The ANA is an anti-nuclear antibody. Now, in the olden days, this ANA was kind of the screening test for lupus. Lupus, you may know, is a connective tissue disease. It can be very dangerous. It's really not a good thing. It's not something that you want to have. But it's really a marker of inflammation in the body. It's a marker that your immune system is doing something. So nowadays, if somebody's going to try to diagnose you with lupus, they may start with an ANA, but there's about 20 different tests that come after that. Most of the time, what ends up happening is that there's nothing specific that's wrong that they can find that's associated with that positive ANA, but the mere fact that it's positive means that your immune system is fired up and is trying to do something. And if that's the situation, then we worry, well, could that something it's trying to do be something that's trying to keep your pregnancy from implanting? So that's the best use of Plaquenil. That's where it has been studied. And in that situation, you can use either 200 or 400 a day, but 400 a day or 200 milligrams twice a day is the best studied dose, especially when used alongside of prednisone. So prednisone, usually at about 20 milligrams a day, and Plaquenil, 200 milligrams twice a day for those people who have a positive ANA and are doing an embryo transfer. That's kind of how That one works. Kate Balky, good evening. Nice to see you here. And you said I did 60 days of Oralissa. I did an FET and it failed. The doctor recommended doing 30 more days of Oralissa plus letrozole. Does this make sense? Well, I got to tell you, when we know that BCL6 is positive, the data tells us that the best treatment is 60 days of suppression. Now, when using Oralissa and letrozole, the evidence there is actually using Lupron and letrozole more than Oralissa and letrozole. And I wouldn't necessarily jump to that to think that that's the best idea, because it depends on what kind of embryo you transferred. A single embryo transfer would not necessarily, sometimes it works and sometimes it doesn't. I may hear stories about somebody who's transferring a day 3 embryo. Well, if it's a day 3 embryo, we don't know if that embryo is going to work or not. If it was a euploid embryo, then, well, all right, there's a 65% probability that embryo should have stuck. So does doing more suppression, is more suppression better, is really the question. And so far, the evidence tells us that more suppression is just probably not so necessary. 60 days ought to be enough. Now, if your doc thought that, well, adding another 30 days wasn't going to harm anything, I can't say that it wouldn't necessarily harm anything, but I just don't know that it's going to help anything. But let's talk about the difference between why letrozole. Why would you add letrozole when you're already using Lupron or Oralissa? Well, the Oralissa and the Lupron work at the level of the brain. They work at the level of the pituitary, and they literally pull the plug on hormones that are telling the ovary to make hormones, really, that feeds the endometriosis. But letrozole works a little differently. So even if we're trying to turn off your estrogen, when we turn off that estrogen, you're still making estrogen. Where does that extra estrogen come from? Most of the estrogen comes from the ovaries, right? Well, the extra estrogen comes from places like this. Any place that you have a fat cell. A fat cell takes your testosterone and converts that testosterone to estrogen. So what does letrozole do? It blocks the conversion of testosterone to estrogen. So you've got the Lupron or the Oralissa aspect that's telling the brain to tell the ovaries to shut it down. And when you add letrozole, there's some evidence to show you may get a slightly improved outcome. What that's doing is turning off what we call the peripheral estrogen manufacturing, which happens at the level of the fat cells. And I'm always hesitant to say, fat cells, because it sounds like it's too judgy. It's judgmental. But we all have fat cells. Underneath our skin is a layer of fat. Everybody has it. Doesn't matter how thin you are or not. It's just there. But those cells convert testosterone to estrogen. A special good evening to Lisa at MCRM. Thank you for being here and for being such a good sport the other day. Appreciate that. A hi goes out to Jessica this evening. And Jessica asks, if you get your day 1 update and you have some embryos that show signs of fertilization and are being watched, do they ever turn around and form blasts, or should you keep your expectations lower? No, I think that's a great question, Jessica. And the answer is yes, absolutely. So what happens is you get your eggs, right? You retrieve your eggs. They take one sperm, put it inside each egg, and that creates an embryo. So the next day, what the embryologist is doing is looking under a microscope to look for signs of fertilization. But remember, just because, and what do I mean by fertilization? Well, you've already taken a sperm and placed it inside the egg, but lots of cellular things start happening. The cells start dividing. It starts creating things like polar bodies. polar bodies, and that's what they're looking for. And without going too much into the embryology of it, that's how they know that something is fertilized. Well, look, they're not looking at those embryos all day long under the microscope, right? They have a particular time that they pull the dish out of the incubator and they look at it. And so what they're saying there is that, they're looking at it in this one narrow window. And if it's moving a little bit slower, or if the actual cell division didn't start to take place, the dividing of the cells didn't start to take place until a little bit later, that narrow window, when they happen to be looking under the microscope, may miss the opportunity that that embryo is actually growing. And that's what that means. It's showing signs of fertilization, but they just keep it and then they look at it again a little bit later to see if it is continuing to grow. So that too is not an abnormal thing to happen, Jessica. And I think that you can absolutely feel reassured by that. That is definitely moving in the right direction. So good deal there. Hi to Golova, it looks like. Let's see what else. Liz Carmen, hello, good evening. And Tracy in Miami, thank you for being here. Angela says, I have a positive ANA and other immune issues and blood clotting. Yeah, so that is the indication for using the Plaquenil with the prednisone, that positive ANA. The one other medication that I do feel very strongly about is a medicine called tacrolimus, also known as Prograf. Tacrolimus is really one of the best studied medications for those who have a history of implantation failure, meaning to say you put in an embryo and it should stick, but it doesn't. You keep having embryos not stick. That's what we know as recurrent implantation failure. And one of the theories there is that the body is blocking, is creating an immune response against the pregnancy, almost like an organ transplant, that you get a kidney transplant and your body is trying to block that kidney. It's trying to reject the organ. It's trying to reject the pregnancy. And that's what the tacrolimus does. It's 1 milligram 3 times a day, or 1.5 milligrams twice a day, either one of those. That must be the dose. If you are getting a dose that's less than that, the evidence shows it is not as effective. The studied dose based on the current best available literature is 3 milligrams a day in divided dose. Now, here's the thing. If you're taking Plaquenil, you can't take it together with Prograf or tacrolimus, because the two have an interaction. They can cause a little funky something with a heartbeat. And so we typically don't do that. Usually what happens is that you stop, Plaquenil, ideally you may start, really even a month before you start to do your embryo transfer. So hopefully you're on the Plaquenil for a while, but you stop it anywhere from 3 to 5 days before you begin the tacrolimus. And the tacrolimus usually starts at the time of your progesterone start in a medicated cycle, or if you're doing a natural cycle, at the time at which you ovulate. So that's kind of how that one works. Denano, hello, good evening. Are Orlissa and Lupron, Kate asks, Orlissa and Lupron equivalent, or is one better than the other? Good question. So Lupron was the only medication that we had to treat endometriosis for, probably 25 or more years. It was the only thing we had, the only gun in the arsenal for endometriosis. And then came out the oral medications, Orlissa being one, Myfembree being another. And basically what it did is that it gave us options. Many people will tolerate the oral medication a little better than they do the injectable medication, because it's a little bit more selective in terms of how it shuts down the hormones. The other kind of nice thing about it is that, well, rather than getting a shot and then being locked into it, you are able to take a pill every day. And so people kind of feel like they have more control. Now, the truth is that the evidence says they really ought to be equivalent. Like I say, I really feel like the Orlissa or the oral medication is a little better to tolerate. There are times that I say, gosh, you know what? Let's say that we did some Orlissa suppression the first time, and then the patient went back, did a couple more transfers, and still didn't get pregnant. And we know they're BCL6 positive. In that scenario, I would say next time I want you to use Lupron. In general, they should be equivalent. So I think you could feel good about either. Into Pinot Journey, nice to see you, my friend Angela, in the great state of, oh gosh, I always wanted, first I was going to say Missouri because we're talking about Missouri. And then I want to say the state of Minneapolis. And then I want to say the state of Wisconsin. It's Minnesota. I know where it is. I know where you live, and I'm very glad to see you. Good evening. Thank you for being here. I just have a hard time with it. Minnesota, all those things that start with an M. Kaylee Gordon, the wonderful, talented nurse practitioner who used to work here at New Life Fertility, has joined, and a very special hello to you, Kaylee. Kaylee is going to be having a baby very soon, so we are excited for her. Let's see, Plaquenil, Angela is saying, different Angela is saying, I started Plaquenil a week before my FET. Will it still work a little somewhat? And the answer is yes. Anything is better than nothing, but optimally, if you have a positive ANA, I want you to start that Plaquenil, if you can, really in the month before you're going to do your FET. Worst case scenario in the very beginning of that cycle. But if you can get some Plaquenil, hydroxychloroquine on board before you start that cycle, that's really when it works best. And again, with that positive ANA, the best available evidence is hydroxychloroquine or Plaquenil along with prednisone. It is time for the 5:30 Fuzzies with Fink. And if you're just joining, I'm very happy to have you here this evening. We do this Fink and Friends thing every Tuesday evening. I am Fink, you are friends, and we get together to talk about all those things that are important. I am based out of Pensacola, Florida. We have offices here along the Gulf Coast in Mobile, Alabama, and in Panama City. I also work with some wonderful colleagues at the Missouri Center for Reproductive Medicine in Chesterfield, Missouri, and in Tulsa. It is an honor to be here with you this evening. Throw your questions my way, would you? But first, I want to take a moment to acknowledge everybody out there who is going through a hard time. And I have a special favor to ask of you this evening, myself personally. So I hope you'll allow me. I always say that this fertility thing is not the book of your life. It is just a chapter. And what we're trying to do is to rewrite this chapter. But sitting there and having to read what you've written on any given day can be a real challenge. It is a very difficult roller coaster to be on. It's a tough place to be. It's hard because we don't know what happens at the end, that the outcomes are never guaranteed. And that can be very frightening. It can be very lonely, not just in terms of having to deal with fertility, but let's talk about work. Let's talk about school. Let's talk about relationships. Let's talk about neighbors. Let's talk about what we see on the news every night. It can feel very lonely and scary out there. This is the opportunity that we all have to take a moment to send out those positive vibes, to stand together as one community with our arms out to everyone who is in need tonight, to everyone who needs to feel that they are not alone, to everyone who needs to know that tomorrow is a new day and it's full of all new adventures. That's what we do right now. And my personal favor, if you would, is please send some good vibes my way. My beautiful mom is in the hospital tonight in Mobile, Alabama. and we are wishing for her a very speedy recovery. So, fond wishes to everyone out there who needs it, because this is a group of people, as I say every week, who would give the shirts off their back to help other people who are in need. So let's do that tonight. Random acts of kindness to strangers really do make a difference in people's lives. Smile at someone who doesn't see it coming. Give somebody a gift just because. Be nice to people, and know that that those things really pay back multifold. Thank you for your prayers for my mom, and your prayers and warm thoughts for everyone who's out there. That is the Fuzzies with Fink. And so, if that was your first time being with us for that, try to get your friends to join next week, even if it's just for a couple of minutes on the program and a half past the hour, because I want to break the damn internet with all this with all this happiness and good cheer. Really, I think we can make a difference in people's lives. And sometimes it starts with just thinking about positive thoughts. Rosa asks, how long do you recommend between live birth and a second embryo transfer? I had a vaginal birth and I'm breastfeeding and I'm 23. Well, so the first thing is we want you to be done with breastfeeding, because the medications that we will use for embryo transfer can be harmful to the breast milk supply, and can ultimately have an effect on the baby, because we're talking about using hormones, and the baby doesn't need extra anything more there. The American Academy of Pediatrics says that if you can breastfeed, ideally you breastfeed for a year. Now, some people can't do that. Some people don't want to breastfeed at all, and that's okay too. But the evidence for interpregnancy interval is that, well, we don't want it to be too short, because a short interpregnancy interval is really the only preventable risk factor we have for severe preterm birth. So we don't like people to get pregnant right away after they have a baby. It really disposes you to preterm labor the next time around. The best evidence is 1 to 5 years. Now, that's 1 to 5 years to actually have the baby. So see is folks who maybe have a 9-month-old at home, who are wrapping up the breastfeeding, starting to wean, or haven't breastfed, or have already weaned, who are ready to start. And I say in that scenario, it's okay, because the issue is not kind of when you get pregnant. It's sort of, well, all right, so you only end up with a little bit of time within that 1 year mark. And I think that's pretty much okay. But best evidence says that the ideal interval between children is 1 and 5 years, and take into account that the pediatrics folks would love to see you breastfeed for a year if you can. Hope that makes some sense there. And let's see what else we got going on here. I got a question through. By the way, if you don't want to throw your question out here on the live, we also can do that by email, and you can email me at Ask Fertility with Fink at firstfertility.com, and we'll try to get to those questions in the next program if you don't want to ask here live. But I got a question regarding it had to do with PCOS, and the first question was, well, how do you diagnose PCOS? What is polycystic ovarian syndrome? And how does it change things in terms of IVF specifically when people are going to get pregnant? So let's take a moment to talk a little bit about this very common finding of polycystic ovarian syndrome. There's a couple of different things that I think. You've got ovaries that will sometimes behave like polycystic ovaries. But then you have something else that's called a polycystic ovarian syndrome. So let's talk about what that means. I think of it as a three-legged stool, polycystic ovarian syndrome. One leg of the little stool has to do with the ovaries. And polycystic, people say, oh, I've had cysts before. Does that mean that I have polycystic ovaries? No. What we're talking about is that when we look with ultrasound and we see a lot of follicles. A follicle is an egg house. So normally at the beginning of a cycle, of a menstrual cycle, your brain tells your ovaries, give me some eggs. And the ovary says, okay then. And so it dips down into its well and it pulls up some follicles, little egg houses. They're literally little tiny sacs of fluid with a microscopic egg on the inside. So we can actually look with ultrasound and can count those eggs, those follicles in the ovaries. And depending on the criteria you use, any more than either 9 to 12, I typically think of 12, more than 12 follicles in any ovary is certainly consistent with what we'll call polycystic ovarian morphology. In other words, the ovary looks like a polycystic ovary. Well, what's the problem if you have a lot of eggs? Don't you want a lot of eggs? There's millions of eggs in the ovaries anyway. So why does having a bunch of eggs there really make a difference? Well, because when you have all those eggs together, under normal circumstances, what happens is that those eggs start to fight with one another. I always say they bicker, they scratch each other, they pull each other's hair and call each other names. They fight with one another because one of them is trying to emerge as what's called the dominant follicle. The dominant follicle is the one that will go on to get released. It's the one that gets ovulated. Well, when all those little follicles are hanging out together and they're fighting, you may end up with a situation that one of them can't become the winner. And so maybe one doesn't get released at all. And that results in what we know of as chronic anovulation. Ovulation is when you release the egg. Anovulation is when you don't release an egg. And anovulation is very, very common in women with polycystic ovarian syndrome. They just don't get a period because they don't release an egg. Now, everyone is not getting a period with PCOS. There are some folks with PCOS who still get a period every single month, but still can meet the other criteria. What's the rest of the criteria? Well, leg number 2 of the stool has to do with the way the body processes testosterone. Sometimes the testosterone level itself is high, that we can do a blood test and see that, oh, look at there, your testosterone level is higher than is expected for a female. And that normal, upper limits of normal is roughly about a 40, depends on which lab you use. But sometimes it's not so much that the absolute level of testosterone is too high. It may be that, well, the body is speaking in a language of testosterone in a normal tone of voice, but the body is hearing that you're screaming in terms of testosterone. So we can check some other markers that will tell us whether that's the situation. But testosterone is prong number 2, leg number 2 of that stool. And that's what leads to things like hair growth in places that you don't want it. Hair loss in places where you do want it growing, as well as some things like acne and oily skin, kind of especially in the T-zone along the jawline, hormonally sensitive acne. That comes from that testosterone. The third prong of the stool has to do with the way you process your carbohydrates. It has to do with insulin resistance. And what is insulin resistance? So our bodies want to maintain a level of blood sugar that is what we'll call a normal range, kind of between here and here. All right. So if this is the normal range, and let's say your blood sugar is kind of hanging out along here, let's say we stop and we drink a Coke and eat a Snickers bar. Well, what happens to our blood sugar? The blood sugar goes bing, and it goes up here. It actually does make that noise, by the way. Bing, it goes up here, and blood sugar comes up here, and the body says, whoa, 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 wait a minute. That blood sugar's too high. We got to bring that blood sugar down. So what does it do? It makes insulin. Insulin comes up here, takes this blood sugar and brings it back down into the normal range. That's the job of insulin and its effect on glucose or blood sugar. But if you are insulin resistant, it means that you got to make more and more insulin up here in order to get that blood sugar back down where it belongs. Insulin resistance is also a very, very common finding in polycystic ovarian syndrome. And it's a very common finding just in what we call metabolic syndrome alone. It's one of the most common metabolic abnormalities that I see in my work in the fertility world. And it's something that probably is associated with premature aging. It's certainly associated with high blood pressure and heart disease and high cholesterol. So that insulin resistance thing is something we really all want to pay attention to and all want to be able to treat. So that's what polycystic ovarian syndrome is. How does it relate to fertility? Well, certainly if you're not releasing an egg, then you can have all the sperm you want, but they don't have anything to do. There's no place for them to go. So that's part one. In the IVF world, it means that, well, we need to take into account how the body is going to respond and what kind of stimulation protocol we're going to use in order to get the body to give us some eggs. So that's sort of polycystic ovarian syndrome in a nutshell. I hope that was useful. A special hello there to Daisy. I haven't seen you for a while. Thank you for being here down in Miami. And to Zenaida, thank you. She says, sorry I'm late. You're always forgiven, my friend. Thank you very much. Happy to have both of you here this evening. And I hope life is good and warm in Miami. You know, by the way, all the Olympic athletes, they had to all go back through, they had to all come back in through Miami International because of all the snow up in the Northeast. And by the way, if you're in the Northeast, our thoughts are with you tonight because it's mighty cold and mighty snowy and mighty messy. But the kids got a day off from school, so how bad can that be, huh? How bad can that really be? Good evening to Ralph coming on the Facebook side, who says, after dealing with infertility and doing IVF, we got pregnant naturally, but suffered an ectopic pregnancy. Is there still a risk for an ectopic pregnancy if we do an embryo transfer, a frozen embryo transfer? Well, so first of all, Ralph, I got to say, I sure am sorry to hear about that ectopic. It is it is a cruel twist of fate, to be able to get pregnant spontaneously and then to have a pregnancy that's not going to continue, either because it's a miscarriage or because of the ectopic. An ectopic pregnancy is a pregnancy that implants in a place where it's not supposed to be. Where is it supposed to be? It's supposed to be inside the uterine cavity. The most common place that an ectopic occurs is in the fallopian tube, or a tubal ectopic. And the reason for that is because, well, in normal fertility, sperm swims into the uterus, goes into the opening of the fallopian tube. The end of the fallopian tube grabs the egg and pulls it inside, and sperm and egg meet together there in that fallopian tube. Well, sometimes that fallopian tube can have some issues. It can have issues like maybe there's some little speed bumps in there. Maybe there's a little bit of scarring. Maybe something has happened to the little hair cells, which are called cilia, that pull the egg and the sperm along, the embryo along. But for whatever reason, that embryo can get stuck. It can stop in the fallopian tube and start to try to grow. And as you can imagine, a fallopian tube is a pretty small little area, and it's not going to accommodate a pregnancy. So as that pregnancy grows, you run the risk that the ectopic can burst or rupture. And so that's why an ectopic pregnancy can't continue. Now, ectopic pregnancies in those who have a history of fertility problems is a recognized thing that happens. We know about it. We should watch for it very carefully because it does happen. As far as a risk of ectopic when doing an embryo transfer, so there is always going to be some risk for ectopic But if you've had one ectopic pregnancy, your risk for having a second ectopic pregnancy by natural conception for the first one is as high as 30 to 50%. With an embryo transfer, the ectopic risk is about 1%. So it's a very, very tiny risk, but it can happen. That risk can sometimes be elevated depending on the type of embryo that you're transferring. So if you're transferring a blastocyst, it is a lower risk for ectopic. If you transfer a day 3 embryo, if your clinic does that, a day 3 embryo actually does have a higher risk for ectopic. Why is that? Well, realize that a day 3 embryo, by the time an embryo is day 3, it's actually still really in the fallopian tube. It may not have moved from the fallopian tube into the uterine cavity yet. So there may be something, what we'll call a chemotactic factor, which means something chemically that's pulling that embryo up into the fallopian tube. So the answer is, unfortunately, yes, there is a risk, but the risk is very low. And we typically follow you so carefully after an embryo transfer that we know from the very, very beginning whether there's a risk for an ectopic given the way your numbers will rise. So 2/3 of normal pregnancies will have that beta HCG double in 48 hours. So that's kind of the number that we're looking for. Allie Sanders, good evening to you. So glad I was able to meet you this weekend. It was my pleasure. You made the process so easy. Thank you so much. And it was a pleasure to meet you. You guys are very good souls, and I'm really, really happy that I got to be a part of your life. So thank you so much there. Angelina Foxy says some nice things here. Praying for your sweet mom, Emily. Thank you. May she have the best docs providing care from her for her. If you had one day 5 BA embryo, 2 day 6 BC embryo, and 5 day 3 embryos, would you first implant the day 5? The answer is yes. A day 5 embryo is always going to perform a little bit better than a day 6 embryo, but I got to tell you, they're pretty similar. Nevertheless, if you're looking at just statistics alone, I don't like to draw a huge distinction between a day 5 and a day 6 embryo, but the day 5 embryo is also a better quality embryo, being a BA there. And as a day 5, the embryologist would say, yep, that's your best embryo. That's the one that you should put in. I would rather see, if you're going to do one embryo, that's what I would do. The day 3 embryos, again, I'm not as excited about. And I've always said there's nothing wrong with a day 3 embryo. Just that if it doesn't stick, then we don't know, was it an embryo problem? Was it a uterine problem? It's very hard to say that because most normal embryos, if they make it to the blast stage, we know that it's going to give you a higher probability of pregnancy. And so that's why many programs will only transfer those day 5 embryos. The problem is with the day 3 embryo, you're likely going to have to do more unsuccessful transfers until you get to the one that may stick. And so that's the challenge with those day 3 embryos. Angela, thank you so much for your very kind words for my mom, Emily. I appreciate that. Let's see. Ralph says the doctor, going back to the ectopic, was able to save the tube and told us there wasn't any damage or scarring inside the tube. Well, I would say that's not true. It may be that, if you had surgery on that tube, you had what's called a salpingostomy, but there was damage to that tube on the inside to begin with. And that's what caused the ectopic to occur. Now, it may not be visible damage. It may not be that the tube itself is overtly blocked, but it means that there was some damage there. And the fact that now there was an incision in that tube and an ectopic removed from it, the tube itself may look real good, but there is still very much a very real risk for an ectopic pregnancy if you conceive naturally in the next cycle. Having one ectopic absolutely increases the risk for future ectopics because of the fact that there is damage in the tube. Now, that said, it does not increase the risk of ectopic with a frozen embryo transfer. I'm talking about only from a spontaneously conceived pregnancy. And I got to tell you, that is one of the things that happens sometimes, is that people go through this process of IVF and then they throw up their hands and say, oh God, this is so frustrating. And then they say, we're going to take a break for a little bit. And they spontaneously get themselves pregnant. There's nothing like I always say, the very therapeutic visit to the fertility specialist, because just being around us seems to make people kind of start to get pregnant on their own. So, and that's a great way to get pregnant too, by the way. So there you have that. I wouldn't say, oh, you can't get pregnant spontaneously, Ralph. I want to be 100% clear there. It just means from the earliest moment that you know you have a positive pregnancy test, you just want to follow that, because ectopic pregnancies can be treated with medication. They don't need to have surgery if they're caught early, but the key is catch them early. So no matter how you guys get pregnant next time, from the moment that you know you have a positive pregnancy test, I would be following your betas. Let's see, Zamanarima, if I said it right, I'm sorry. By the way, hi Midgie, thank you for being here. Is 4C a 4-celled day 3 embryo good? Should it be transferred? So a day 3 embryo is typically 6 to 8 cells. So that tells me that day 3 embryo, if it's 4 cells, may be growing a little bit slower, and so therefore it may be less likely to be normal. Now, we can't say for sure, but if you asked for my opinion in the statistics there, I'd say, well, look, friend, if that's your only embryo, well, then of course transfer it, because it always has the possibility that it can get you a baby. But I would feel guarded about it. If you have other embryos, there may be other embryos might be a better choice. Amber says, if I did IVF for male infertility, will my OBGYN still consider me high risk, and why? If I did a modified natural. Well, so it's a complicated question. High risk, what does a high risk pregnancy really mean? There are some conditions that are overtly high risk. Like, let's say you have a history of a short cervix, severe, preterm labor. You have very high blood pressure. You have some chronic underlying disease, kidney disease or liver disease or heart disease. These are obviously high risk type pregnancies. You have seizures. You have some underlying medical condition that makes you high risk. The mere fact that you had an embryo transfer does not increase your pregnancy risks per se. Okay. There are some slight increased risk with medicated cycle embryo transfers. It can increase the risk for potentially for blood pressure complications in pregnancy. Some people would say, well, gosh, based on age, if you're 35 or over, that's considered a high risk pregnancy because you're advanced maternal age. But what does that really mean? What are they going to need to do differently? The mere fact that you had an embryo transfer does not make your pregnancy high risk. Now, some doctors will say, gosh, well, yeah, but you invested so much in order to get pregnant. They want to make doggone sure that everything is done right. And so maybe they send you for serial growth ultrasounds. Maybe they want to keep looking at the blood flow that's going through the placenta. Maybe they want to think about inducing you at 39 weeks if your cervix is favorable, so as to decrease risk for the placenta getting tired. If so, that's really based more on the idea that you did something special to get pregnant, not because what you did to get pregnant carries with it any particular higher risk. So it depends on the doctor. It depends on the pregnancy. But honestly, Amber, you should be a pretty normal pregnancy, as normal as you can be. That's the caveat there. But the pregnancy itself, I think really ought to be fine. And I am so excited for you. I am levitating. I can't tell you how excited I am. Thank you, Rosa, for your kind words. A. Clark says 20 days post a day 5 transfer. HCG is rising normally, just started heavy bleeding and cramping this morning. Went to the clinic and saw a little heartbeat. Doctor confirmed that it looks okay. What's the cause of this kind of thing? Well, I will tell you, it's scary stuff, man, right? It's really scary. What happens most commonly? Why is it doing that? Very commonly, 50% of pregnancies will have some cramping and bleeding in the first trimester. And when we look and we see that heartbeat, that's the best odds that we can hope for. 95% of those pregnancies will continue on without having a problem. And that's really good odds. But what causes it most commonly as the pregnancy, as the uterus grows, the placenta will move along with it. And as it moves along with it, it can shear off a little space that's underneath. And that space is what's called a subchorionic hematoma, or a bruise that's literally under the placenta. Now, like any other bruise that you get, your bruise turns color and eventually it just kind of resorbs and it goes away. When you have a bruise that's underneath the placenta, the cervix is pretty close by. And so sometimes, there's just a little easier access of that blood to get out the door. And so it results in vaginal bleeding. Now, with a subchorionic hematoma, there is, and if they didn't see that, I'm not saying that that's what you have. Oftentimes you can see a subchorionic bleed, but if that is the case, there is some evidence that taking a supplement that's known as alpha lipoic acid, 600 milligrams of alpha lipoic acid, can decrease both the amount of bleeding and the risk that a subchorionic hematoma will continue to expand. Because we have to worry, if you get a bruise that's underneath and if you get a bruise that's underneath and it keeps growing, you run the risk that it can grow to the point where it can separate out the placenta. And that's what ends a pregnancy. So if there's any question that it was a subchorionic hemorrhage, 600 milligrams of alpha lipoic acid along with your progesterone can diminish that risk. Now, what else? Sometimes it may be a little blood vessel in the cervix that's just as the cervix is starting to soften up. Sometimes it may be a little blood vessel that's supplying the endometrium. As the uterus grows, it just opens up and causes you to bleed a little bit. But again, gosh, my fingers are crossed for you there, because it is one of the scariest things to happen in your pregnancy, to have that kind of bleeding in the beginning. But when you look and you see that heartbeat, 95% is the chance that everything is going to be just fine. Let's see, can endometriosis come back? Yes, endometriosis is a chronic condition that does not typically completely disappear until ultimately when you are in the menopause. Should I take antibiotics before a retrieval? Well, antibiotic is not something that would treat endometriosis. Again, we have to treat that hormonally. Usually we do use a little antibiotic before an egg retrieval just because we want to lower some of the colony counts. We're placing a needle that goes through the vagina, which is full of bacteria, into a sterile space, which is inside the pelvis there. So I do think antibiotics are a good idea. But endometriosis is a hormonally treated issue, not so much one with antibiotics. Folks, we are going to be out of time tonight. I hope you will join me next week at the same time, 5 o'clock Central, 4 o'clock in the mountains, and 6 on the East Coast. Fertility with Fink is my favorite place to be every single week, and I'm so honored that you would be willing to spend a little bit of your time here with me. As I said, this fertility business is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite that chapter together. Every step forward with kindness, every step forward with love, and every step forward, most importantly, with hope. Because tomorrow is a new day and it's full of all new adventures. So until next week, I'm Dr. Randy Fink. Thanks so much for being here, and good night.